really, when we move into treatment of these cancers, so at your institution, what is the process? Like a patient comes in with a newly diagnosed gastroesophageal cancer, who needs to see them and why?
Right. So, I think that, if we sort of think of locally advanced disease versus advanced or metastatic disease, I think that there is a utility of a multidisciplinary effort for both cases, but particularly for the locally advanced disease, because if it's a type 1 GE junction cancer or distal esophageal cancer, often you're thinking of trimodality therapy involving medical oncology with chemotherapy, radiation oncology, and then surgery. Sometimes you might do chemotherapy and surgery alone. And then for the metastatic patients, it's also important because there may be palliative approaches that you need to consider as well. So I think it's really quite critical to have a multidisciplinary approach. And then also the other benefit of that is actually having the pathologist there and the genetic counselor and nutritionist, and these are all aspects of managing these complex diseases of the foregut that can actually improve patients' lives and actually how they tolerate the disease.
Yeah, it definitely takes a village in treating these patients.
Yes.
It's fairly intensive. I know personally, I tell my patients with locally advanced disease, when they're getting neoadjuvant chemoradiation therapy, I tell them, this is going to be a really hard road.
Yes.
But we're going to get you through the road. We're going to get you through surgery, but it's going to be about 1.5 years to you're
before you feel better.
feeling
Yeah.
better. And that's such an important
You're
message to
absolutely
give so
right.
the patients know, where they're going. Certainly across the pond from the US, in the UK, and it also in Europe, there's different treatment approaches to locally advanced disease. What do you think?
So I wouldn't say it's too different. We do take on, all the evidence together. And again, I really echo what Manish just said. We have, a multidisciplinary approach is really, really important. In fact, all our newly diagnosed patients have to be discussed in the multidisciplinary team meeting. And, we will have a similar, members, medical oncologists, radiation oncologists, surgeons, gastroenterologists, dietitians, and specialist nurse, actually, because I think a lot of times we do find that information, as you said, to the patient and the nursing support, psychological support is actually very important. So in terms of treatment approach, there are different approaches. I think a lot of it is based on randomized control trials that are done in different geographical regions and therefore are done different ways. So we certainly, in a local advanced or T2, T3 gastric cancer, we think about a perioperative approach, and that's based on originally the MAGIC trial, which is then supplemented by the French study. So we give chemotherapy before and after. But perhaps the most important thing and the newer data that we are generated is I think the improvement in survival, in fact, are coming from better staging investigations. So we really, we have better CT scanners now. We do PET scan in our institution, even for gastric cancer. I know that is debatable. There's certainly, about 15% of the gastric cancer are PET negative. But we do feel that is an important part. We do pick up peritoneal disease. We do pick up bone metastasis on PET scanning. And then our surgeons do routinely also perform laparoscopy before preoperative chemotherapy. And then a patient obviously then seen in our clinics to assess their suitability for chemotherapy. Now, for the junctional tumor and certainly for the lower esophageal cancer, we have taken on the data from CROSS using carboplatin paclitaxel in conjunction with radiation. The practice is changing. Certainly there are sites in the UK and there are many sites in Europe who would use a preoperative chemoradiation approach. And a lot of centers are getting very good results from this approach. So I think certainly in the lower esophageal and the OG junction tumor, that's a chemoradiation approach is also part of the standard.
Now, do you do endoscopic ultrasound in staging?
Okay, so we do endoscopic ultrasound for esophageal and esophagogastric junction adenocarcinoma. We debated a lot, and we, in the end, still don't see a lot of extra benefit of doing endoscopic ultrasound for gastric cancer. we hardly ever see T1 tumors in our routine practice. I can understand if you have a T1 tumors, they might want to do endoscopic ultrasound to ensure that that really is T1. But really, in our everyday all-comers through our clinic, I mean, that is not really the average patient that comes through our door.
Now, Manish, we saw recent data at ASCO looking at gastric cancers and chemoradiation versus chemotherapy. What was your interpretation of the data, and how have you brought it into practice?
Sure. So, yeah, and this gets to what was said about sort of differences in practice. In the United States, a standard approach is after surgery to do chemotherapy with radiation, but then sort of in the same era, the MAGIC study showed the benefit of perioperative therapy. And so there was a very nice study performed by Chau, who did chemotherapy neoadjuvant followed by surgery, and then there was a randomization to more chemotherapy as per the MAGIC paradigm or chemoradiation. In this study, they actually showed no difference in the outcome between the two arms. So it suggested that continuing chemotherapy in that setting is probably still a standard approach, and combining the approaches, doing chemotherapy, neoadjuvantly surgery, and chemoradiation, sort of a meld of the MAGIC and intergroup 116 data, probably doesn't actually add benefit. I think that from what we've learned from a drug development standpoint is that we need to maybe look at other targets. Dr. Janjigian has a very nice study in the adjuvant setting with a TKI in high-risk patients. So, something like that might be very helpful to move the field forward.
Now, really interesting with this study, and a lot of controversy that ensued, was about the surgery the patients had compared to how we do surgery. So I don't want to bust on the United States, but this is where a lot of the discussion has happened, is a lot of how you do in terms of local control of your treatment depends on what surgery you had. Absolutely. And so, Yelena, I mean, big discussion point.
It's a big discussion. We can talk about and discuss for a long time what chemotherapy to give, what backbone, et cetera. But the truth is, and this was very important data actually presented by Christophe Marriott at this Congress, is that patients do best if they're operated on by an experienced surgeon in a high-volume center with a multidisciplinary team approach. And the hazard ratio for death reduction is 70% almost. So, I mean, in a fit, otherwise well patient, the mortality in a low-volume center was as low as 7% post-op within a 30-day mortality. And we're not even talking about cancer recurrence. We're just talking about post-op complications and such. So when approaching a patient who is motivated and is well and going for surgery, complete resection with negative tumor margins and adequate lymph node sampling, which is at a minimum 15 to 30 lymph nodes, is crucial. And the discussion with the team, whether or not it makes sense to do preoperative chemotherapy and then surgery, chemoradiation and surgery, as Ian alluded to, disease management teams are key. And most patients are discussed and imaging is reviewed. I would agree that laparoscopy is crucial to appropriately stage these patients, and majority of these patients with visible tumors and imaging that's clearly states in gastric cancer, probably EOS is not additive.
Yeah, and just some of the nomenclature, you need at minimum, and this would be very minimum, a D1 resection,
Correct.
but D2 is probably where we'd want to go.
That's
so
right.
I think, if you get the patient after surgery, count the nodes on the pathology report, and if you have a chance to get that patient to the right surgeon, it sounds like the most appropriate thing to do.
Yes.
Yeah, I modified D2. The original D2 had a splenectomy, which
Yes.
we don't necessarily do. But you're absolutely right. Having an extended nodal dissection past the N1 nodes.
Yes. And